Okay, good morning, and thank you very much for this great invitation for this talk. We actually have two parts for a talk, going through the landscape of treatment and immune treatment in GU cancers. It's impossible to talk about everything, but I will try to touch the most updated and most important things. I come from Haifa, which is not too far from Kiev, only 3 hours by flight. Haifa is in northern Israel, and I work in Rambam, which is the largest hospital in northern Israel, and it's a referral center for northern Israel, serving a population of 2 million people. So we have a very high volume of patients. I'm very lucky to run the clinical trials unit, which is very large, and this way I'm very, very fortunate to treat our patients with the most updated, in the research process, drugs years before they come out to the market. And I think I'm privileged, and this is really exciting for all our patients and for us treating physicians, because we really feel we always have more options and we never lose hope, and we always try to find other solutions for our patients. So my focus on my talk will be starting with renal cell carcinoma, who's updated. There are a lot of exciting news from the recent ESMO and a lot of practice-changing studies. And I will just touch on this presentation on the treatment of bladder carcinoma and immune therapy in TCC, and I will elaborate further in the second presentation when I do the case discussion. We'll have a case on TCC, and we can do a little more on TCC. So we'll start with taking you through the landscape of current treatment in metastatic RCC. And this is a very interesting tour we actually take in. At the beginning, when I started my work in oncology, the only drugs we could give was immune therapy. Surprise, yes. But interleukin-2 and interferon-2, which didn't give too much to our patients. And very luckily, right after I started, the era of targeted therapies emerged, and we started with a high volume of work in the TKI and mTOR inhibitors. But then this was not good enough, and we came back to immune therapy. And we entered another new era of treatment with nivolumab in treatment of metastatic RCC. And some of our patients also receiving ipilimumab. But this is also not enough. So today we merge all our history paths are combined together to combination therapies that I will elaborate on in my talk, combining immuno-oncology and targeted therapies. And this became a really, really exciting time for us. So what were our expectations treating immune therapy in the older version of our treatment? High-dose interleukin was a wonderful treatment when it worked, but it worked for a very, very small fraction of the patient with a very selected disease, mainly clear cell, metastatic to the lung, comes with a very high toxicity and providing about 5% complete response with a 50% response rate. Very few patients had a durable response. Those who had a durable response, it was amazing. But this wasn't the benefit of the majority of the patient, and we couldn't continue that treatment for a long time. Chemotherapy has no role in the treatment of metastatic RCC. Luckily, in the past decades, 11 agents were approved for the treatment of metastatic RCCs, mainly target TKIs, mTOR inhibitors, and VEGF inhibitors. in the recent years, nivolumab, combination of TKIs and mTOR inhibitors, newer agent of TKIs, and tivozanib, which is another TKI, was just recently approved. Sorry, the other way. So the studies that are leading for the approval of this of all these agents are outlined here, and they actually, some of them were approved based on progression-free survival benefit, and some of them, very few of them actually, had a real overall survival benefit. Interestingly, all the first-line agents were not approved based on overall survival benefit, and the nivolumab was the first agent in the second line to be approved based on the second line overall survival benefit. So when we try to look back and see where we are today, is there a real benefit for our patients? Do they live longer? What we see here is the Mozart criteria group assessment for good, intermediate, and poor risk criteria based on their performance status and their LDH, hemoglobin, calcium, and time from diagnosis to treatment that you're all probably aware of. And we used to, in the interleukin area, in the older immune therapy area, we expected up to 30 months of survival for the good risk and 5 years survival for the poor risk criteria. And then years later, 10 years later, in the era of TKIs, the Hang criteria that are slightly different, looking at neutrophil and platelets as well, looking at different numbers of survival. All of a sudden, from 30 months, we are looking at 43 months for favorable risk, intermediate at 22 months, average median survival, and poor risk is a little better than it used to be. So in the era of TKIs, things are looking better for our patients. Although the drugs were not approved based on overall survival, the overall survival is boosted up. And this is before the era of immunotherapy. So the guidelines are very clear about treatment in the first line in the metastatic RCC with sunitinib or pazopanib, a combination of Avastin and interferon that is hardly used in currently. So we have two main competitors, pazopanib and sunitinib, that were compared in the COMPARE study that you're all aware of, and they have similar results. One will say this way, and the other will say another. But at the end of the day, these are pretty much the same drug. Each physician has its own preference, but the outcome is the same. And real-world data also show eventually the same number, the same survival, whether the patient was treated with sunitinib or pazopanib. So the landscape was clear. Sunitinib, pazopanib. When they progressed, we gave axitinib or Afinitor. This is all we had. And if the patient survived and he could afford it or he had the coverage, he received whatever was left. And we went through one line to another, but no real agent was proved as a pure third line for the treatment of RCC. Second line treatment before the era of immunotherapy showed benefit in progression-free survival, but not in overall survival. Our expectations are very moderate. 4, 5, maybe 6 months of response. Response rate was also very low, 5, 10, sometimes maybe 20% response rate, but this is all we can aim for. No wonder when the nivolumab study was published, the Checkmate 025, we embraced it like a hidden treasure. We were ready for a change and for a new promise for our patients. A lot of sense comes with the treatment of kidney cancer with immunotherapy. As mentioned before in the previous talk, there's a mutation load that is not low in kidney cancer. And this is evolving tumor with adoption of high mutation load as the tumor progresses. So it's not as high as melanoma or lung cancer or bladder cancer, but the mutation load is high enough to make this a target. We also know, as other tumors, that overexpression of PD-L1 in the tumor comes with a poor prognosis, both in clear cell RCC and in non-clear renal cell carcinoma. Even through treatment of TKIs in the first line, the value of PD-L1 expression still shows us the negative prediction of overall survival for patients with high expression of PD-L1 in the tumor. So this is marker a target? Probably yes. So the Checkmate 025 actually studied nivolumab, an anti-PD-1 inhibitor, in the second and third line setting for metastatic RCC compared to Afinitor. It wasn't compared to TKI because the notion is that they are pretty much the same. Some may argue, I may argue as well, but this is a study. The competitor is a weak mTOR inhibitor. And here, over 800 patients were studied with dramatic improvement in the outcome for patients treated with nivolumab, response rate of 25% versus 5%, and few patients having complete response, but a lot of patients having durable response. Surprisingly, with or without PD-L1 expression, the outcome was the same. So PD-L1 expression in the second and third line is not a predictor of response. We see that both PD-L1 positive on the left and PD-L1 negative on the right better response to nivolumab versus Afinitor in the advanced line setting. Those with PD-L1 negative, as expected, have a better prognosis. In addition, most importantly, the quality of life of our patient is improved. So we see they start with a similar quality of life, and the improvement in the quality of life for patients treated with nivolumab versus Afinitor that doesn't have too many side effects is much better. The tolerability is as expected in immunotherapy, and I didn't elaborate that on our talk. So overall survival for this treatment for the first time in the second line and third line setting was crossed and positive for 25 months. We see that also in another study that was published at the time in a phase 2 lenvatinib and Afinitor combination study, but this is a randomized phase 2 versus a randomized phase 3. Later, at the same time, the cabozantinib study was published. They gave cabozantinib TKI, potent TKI versus Afinitor for the second, third, and even sixth line setting, with an improvement in the overall survival compared to Afinitor. This comes with a high cost of toxicity, 60 and 17%, where nivolumab had very minimal toxicity and very minimal dose. There are no dose reduction, but discontinuation due to adverse events. So the landscape had changed. All of a sudden, we give sunitinib, pazopanib for first line, and now for the second line setting, until just recently, we usually give, in Israel, we usually give second line immune therapy, nivolumab. 90% of the second line patients will go on nivolumab. And luckily, it's approved, it's covered, and this is a natural path for most of our patients, and this is based on the Checkmate 025. Cabozantinib is also an option. You can give it as a second line and maybe save it for later for third or fourth line, but this is certainly a valid option based as a survival benefit in the METEOR study. And for some patients, combinations of VEGF and mTOR is also a valid option, but this is FDA approved based on phase 2 study. So we are progressing, we're doing better. but we always want more. Can we make it better? Can we have a better prognosis for our patients? I mentioned 25 response rate with immune therapy. That is a lot. That means that still about 50% of the patients progress through immune therapy. So it's still not ultimate. It's not good enough. Some patients will not respond. And this patient that will not respond to immune therapy, treated with nivolumab, will die very quickly because it doesn't have any reserve. So for this patient, I have one chance. And if not responder for nivolumab, he's not going to go to the third line. And some patients respond dramatically, but we don't know who they are, and we don't have a predictor for response yet. So maybe combination is our answer for our praise. Because when we take croissant and we add a donut, what do we get? A cronut. I'm sure you don't have a cronut in Kiev, but in New York and London, people line up to get a cronut because a cronut is so much better than one of them, and each one of them separately is wonderful. You haven't tried the right one. And in immune therapy, we can also improve the outcome if we combine nivolumab with ipilimumab. There's plenty of data in melanoma patient, in lung cancer patient, and there is, for the last 2 years, data of phase 1 combination of the EP-Nivo studies in renal cell carcinoma. So we are enhancing the immune response. And the real breakthrough comes from a study that is called Checkmate 2014 that was presented a month ago in ESMO. We're very lucky to participate in all these studies. This study actually randomized in the first-line setting based on the phase 1 study, giving this combination to renal cell carcinoma patients, showing double response. They went straight to phase 3 study for the first line this time, combining nivo and ipilimumab, a low dose of ipilimumab. This is 1 milligram per kilogram every 3 weeks for 4 cycles, and then continue with nivolumab alone, versus a standard of care for clinical trials, which is sunitinib. So they continued until progression or toxicity. The results are amazing. They are practice-changing. We see dramatic benefit in the favor of this immune combination, nivolumab and ipilimumab. For the first time, we see 9% complete response. This is a 850 patient cohort. This is a large phase 3 study. Response rate is 42%. This is almost double response rate. Still 20% progressive disease. Duration of response is not reached versus sunitinib for 18 months. That makes a lot of sense. Progression-free survival also showed the benefit, 11 versus 8%, although in immune therapy we don't look at progression-free survival. A lot of time it's the same. And hazard ratio for overall survival is highly, highly significant of 0.63, very, very statistically significant. So a clear benefit in the favor of the new standard of EP-Nivo versus sunitinib. But things are a little more complicated because when they look at the subpopulation, favorable risk versus intermediate and poor risk metastatic renal cell carcinoma, we see surprisingly that sunitinib was much better for the patients that were in a good favorable risk. So they had good labs and a long interval from the diagnosis of the tumor to the metastasis, good performance status, and it's also almost double than immune therapy. So immune therapy is inferior for a subgroup of patients here that is not insignificant, 249 patients. PFS was much lower, 15 versus 25. So things are very complicated, a lot of questions. If we look at the PD-L1 overexpression in the intermediate and poor risk groups, there is no difference if the PD-L1 is negative. In the second-line study, I want to remind you there was no difference. PD-L1 was not a predictor. But in the first-line setting, we see exactly the same results. And the benefit, actually, for this entire study come from a subgroup of patients in the intermediate and poor risk that had a PD-L1 positive in their tumor, staining in their tumor. So a lot of questions are raised here, but a lot of patients now, I know in Israel, I know in the USA, are moving toward first-line treatment with this combination. More data will be available in the upcoming meeting in the ASCO GU and the ASCO in 2018. But for now, it's very clear that a subgroup of patients has a very clear benefit in combination first-line therapy. Quality of life is also better, and you must always keep it in mind that if a patient can afford it, this is also a major outcome that we aim for. This is not a combination for everyone. In the second and third line setting, wonderful combinations are also available. Levantimab and Afinitor show very promising results and are now attested in the first line setting after a successful phase 2 study. Are there other options? This is a patient that had a rapid resistance to sunitinib, and right after that had a rapid resistance to nivolumab. In 3 months' time, look at this disease, how it's progressed in the retroperitoneum. This is a huge mass here. He has massive lymphedema in the leg because of outlet obstruction in the vein with a thrombus, tremendous pain, and this is a very young patient, rapidly progressing, going to die. Can we do something else for him? Because immune therapy, he refused, by the way, to get the EP-Nivo because he was very concerned with the profile, the side effect profile. But he progressed right through it, so there was no time to help him. This is actually the husband of a nurse in our department, in the radiotherapy department. So luckily, there are a lot of new options that are emerging, and they will compete with the dramatic result that I showed you in the EP-Nivo combination. So today we're going back to taking all our past together and mixing it together, immune therapy and TKI therapy, and maybe together we'll win. Look at the phase 1 data from the Keytruda and axitinib study. 71% response rate. Avelumab, it's an anti-PD-L1 by Pfizer, and axitinib. Almost 60% response rate. Those are new numbers, unbelievable. Keytruda and lenvatinib, a potent TKI by Eisai, 63%. So those combinations show very similar results and very, very interesting and promising. Nivolumab and pazopanib, nivolumab and sunitinib, the same with Keytruda and sunitinib and pazopanib are neglected as combination because of very high hepatic toxicity. Don't try it at home. This is why axitinib was elected, because it has a lower rate of hepatic toxicity, but still it's there. We see much higher hepatic toxicity. We have a lot of patients on this study. This is also already a phase 3 first-line study, and it's beautiful. They all respond, it's amazing, but a lot of side effects. So we have to wait. The phase 1 study was published in the recent ASCO with a 58% response rate, and from that point, the study rapidly finishing the accrual, and it will close in 1 month instead of 6 months from now, because these are very promising results. Look at the waterfall plot. But there are other promising combinations. Levantinib and Keytruda, Levantinib Afinitor in the first-line setting, all are compared to sunitinib. And very brave combination, cabozantinib and nivolumab, and triplets for the first time, Cabo, EP, and Nivo. You have to be very brave. We are brave, and we start in the study very, very soon. But please note that all these studies are compared to a standard of sunitinib. And sunitinib is also a change in standard. In the CABOSUN study, this is a randomized phase 2 study, sunitinib bravely was compared in the first-line setting to cabozantinib, a potent TKI and AXL inhibitor and MET inhibitor. Cabozantinib is a very toxic drug, but a little more toxic than sunitinib from my experience. The CABOSUN study showed superiority of cabozantinib over sunitinib, and now is submitted for FDA approval for the first-line setting. And this is very confusing. All our studies now are competing with sunitinib. What does it mean if cabozantinib was to be the competitor? So a lot of unanswered questions. This is very, very confusing. There are a lot of options now for our patients. IO, TKI, TKI and mTOR, and IO and anti-VEGF. This is a Avastin and atezolizumab study. What we do with a patient depends on our experience, depends on the resistance of disease. If it's an early progressor or a late progressor, we treat them the same. It also relies on the genomic profile. Eventually, all those together probably will lead us to pick the right treatment to have patients. Those are dramatic changes, and this is a really new era for treatment of metastatic RCC. We have a lot to learn and a lot of excitement ahead of us. So I'm going to conclude on RCC with that, and then just in the last few minutes that I have, I will give you an introduction to what happens in bladder cancer, in upper tract TCC, in the new era of immune therapy. So in TCC, it's very simple. When we try to look back and see what we had so far, it's easy, nothing. No success, just a little bit of response to chemotherapy, and then they die. So from the dose-dense MVAC in 1981, the Core-Stenberg study, nothing happened in the past 30 years. Nothing very interesting happened in bladder cancer. Vinflunine is approved in Europe. We don't give it because I think it doesn't worth anything, but it has very little benefit, and in the intent to treat population had no benefit in the overall survival. Cisgem is not better than MVAC, and this is how years go by and nothing happens, and then all of a sudden, so many new agents are approved, and all of them are immune therapy. In just 1 year, we have everything approved for the second-line setting. So when we treat metastatic locally advanced or metastatic TCC, we keep our hopes low. We don't have high expectations. We're looking at a year and a half, and that's it. And they have liver mets, we're looking at 6 months. And this is all we can do. And nothing we did actually, nothing that was done, I didn't do it, but nothing that was done actually improved anything. If there's a little benefit, then in the high dose MVAC, we give a lot of that. And Cisgem dose dense does not show any improvement. Adding paclitaxel to GemCis didn't show any durable improvement that is worth the additive toxicity, and it's almost impossible to cross the 14, 15 months of survival. So the dose intensity is better, but it's not enough, and it's very, very toxic. As I mentioned, the vinflunine showed a minor sub-analysis in the per protocol overall survival benefit of 2 months. It's a toxic drug for a lot of patients, and we really don't give it a lot. There are multiple phase 2 studies that are usually held at the beginning of the study after 20, 30 patients, because all of them are very disappointing. All agents were tried, all combination were tried before. Response rate is very, very disappointing, and it's about 10%, with overall survival in the second-line setting of about 7 to 9 months. This is all we can do. So finally, immune therapy also came to bladder cancer. We were very skeptic because after years of nothing working, you don't really expect that immune therapy will do anything. But this is a disease with a very high tumor burden. And like RCC, immune therapy does work here. For local disease, please be reminded you are treating BCG. Now, you, the urologists, they treat with BCG. What is BCG? BCG, for many, many years, for so many years, started in the 70s, the development. And until today, nothing is superior to BCG for local to high-grade TCC. And BCG is immune therapy. It's a local immune therapy. So local immune therapy does work in bladder cancer. So it does make sense that systemic therapy will work, maybe. But BCG just show you activates actually the T cell, and then the T cell attacks the tumor cell. Localized immune therapy. So we're always going back to where we started. There are multiple agents that were tested in phase 1 and phase 2 studies. Atezolizumab was the first one to approved. This is a Roche molecule. Avelumab, this is the Pfizer one. Durvalumab, AstraZeneca. They all show similar results. Pembrolizumab and nivolumab. Things looks very similar in the all phase 1, phase 2 studies. What we see that is common to all the immune therapy in the advanced second-line therapy in TCC is that the patients that respond usually respond quickly within 2 months, and those who respond have a durable response. Not all of the patients respond, but those who respond are very lucky usually. So we'll elaborate about it much more in the case presentation, and we'll discuss who is a candidate, who is not a candidate to treat with immune therapy. This is our center. This is our new oncological building. I sit here and here. This is a research unit floor and the management floor, and this is my clinic somewhere here. Thank you very much.
Dr. Peër, thank you very much. Are there any questions from the audience?
Okay, yes. So we'll keep it for the presentation days, I guess. Okay, I'm on time.
Спасибо за лекцию. Будьте добры, скажите, у вас были случаи, когда вы проводили циторедуктивную операцию и затем мультитаргетную, и без циторедуктивной операции при почечно-клеточном раке?
In RCC, okay. She's asking about cytoreductive treatment with multiple targeted therapies after cytoreductive surgery in metastatic RCC. We do it all the time. We usually, for patient that is not poor risk metastatic RCC, we usually start with nephrectomy, although the data is out yet, and after we start with systemic therapy. If the patient is poor risk and surgery looks too complicated, we neglect it, we don't go into surgery, and we start systemic therapy. So this is our standard. Yeah.
Dr. Peër, I have a question. How can you explain that there's no role for target therapy in advanced TCC?
There's what?
No role for targeted therapies.
Targeted therapy, so many phase 2 study for targeted therapy. They tried everything, and the mutation rate, the acquired mutation rate in metastatic TCC is too fast. It's too fast. And there are new emerging studies of combinations now. Cabozantinib and chemotherapy, something just came up now, and Cabo with immune therapy. So one modality is probably not enough. For subgroup of population, they do respond dramatically for immune therapy. I do have very few patients that are cured with chemotherapy, but the vast majority of patients, none of these are enough, and we are going into combination. All the studies we're doing now in TCC are focusing on combination, whether if it's immunotherapy, we have combination with IDO1 inhibitors. If we are looking at first line, we are looking at combination with chemotherapy. So full dose cisplatin or carboplatin Gemzar plus immune therapy for those patients. And we send them a lot, because we have phase 1 studies, a lot of them, so we try to send them for combinations as well, but not for single modality. This is too aggressive disease.
Thank you.
Okay. Professor Kotten.
Professor Kotten, please.
Following the comment by the colleague here, I have two questions. Number one is like a hypothesis. In the old times, it was a notion that you do the nephrectomy in stage 4 patient, and you should expect regression metastasis. You know, I've been to oncology about 45 years. Maybe I need to be another 45 years to see the first case. But it was said so in the literature, and we did it. So number one, now with the concepts of abscopal effect, maybe we can have an explanation to this phenomenon. But number two, with this fantastic result that you show us here, why do the cytoreduction, why do the nephrectomy say if the patient is asymptomatic, if there is bleeding, whatever, I agree, you know, you do it for palliative purposes, but somebody comes with a mess, he doesn't even know that he has a mess, metastatic disease, please explain to me what is the logic of doing the nephrectomy?
I have a very, very short answer. Old habits die hard.
Sorry?
Old habits die hard. It's very hard. This is what we used to do for the past, I'm used to do for the past 10 years. And the Carmen study is just coming up showing us survival. But sometimes maybe bulky disease is less responsive. But there are no answers, and we need randomized trials to answer it. And it's very hard to change practice without data. It's very hard. I actually saw several regressions after nephrectomy, but just like the literature, they are not lasting. They are not lasting, long-lasting. They regress, but for a few months, and you have to start treatment. So the main driver of all the VEGF is out, and then the tumor supplies its own VEGF, enough of it.
Now, I would just like to ask you a maybe provocative question. Now, with the advent of all these treatments, we see more and more the use of treating metastasis with radiotherapy. And I hope you agree with me that there is no clear definition what is oligometastasis. Sometimes the definition is how much do you pay for each fraction.
Yeah.
But let me be politically
Israel,
not correct.
yeah,
But do you have any guidelines? When will you use radiation for solitary or oligometastatic situation?
Versus when we used surgery?
Versus surgery, versus not doing nothing, just treating the systemic disease without
systemic
the
disease,
targeted
I
radiotherapy.
always study the pace of the disease, and I'm looking for the next scan. And if it's a slow-growing disease, I don't treat until it progresses. So regardless of all the new care, we have a lot of patients that are on surveillance until they're progressing. Usually they stay on surveillance for a year with a good quality of life without treatment and without toxicity. This is the first rule. If there are accessible metastases that are usually 3, 4, we usually try to target them. If there are, there's no rule of thumb, but usually no. I do 2 or 3. Some go to 5, but I feel comfortable with 2, 3 actually. I personally, but I respect if people choose not to give systemic treatment or do 5 to irradiate them or operate. But if it's something that it has a rapid onset, there's no point of doing localized treatment. If it's a very slow progression, and I have those patients that progress over years, there's a lot of sense to it. So I think the first thing you need to know is the biology of the tumor, which is very different from one patient to another. And if you know the biology, you can make a better decision for the patient.
I think it's I certainly agree. I mean, this is, I think, a very clear what you should do, but I think there will not be any studies, and I think the best to do is like do a national or international registration study, look at what you've done with these treating oligometastasis, then get a better definition.
This is
before
such a
it's
huge
likely.
bias
I
because
know.
you treat those the
Yep.
good patients and you compare them to the bad patients.
Anyway, if you do a registration and you
Yeah.
follow it and you know the data rather
Yeah.
than treating individually, never having a summary of the results, which will never give us any answer.
But when we talk about the RCC cases, show cases, maybe you don't have to irradiate them. Okay.
Dr. Peэр, I want to ask a clinical question. We have experience with Keytruda in melanoma and other tumors, and we see the phenomenon of so-called progression. Do you see this the same in acitalizumab, which is just emerging in Ukraine, and nivolumab?
In nivolumab, well, I think not hyperprogression, pseudoprogression is
Pseudoprogression, yes.
overrated, and we see very, very few cases, less than 10%. I see maybe 5% of pseudoprogression, and for those 5%, we actually treat further at least another 50% that have a very slow progression. And we actually, Maura and myself are just starting to collect the data of the financial toxicity of treating beyond progression. So, well, hopefully we'll have the results in a few months.
Allow me one. I mean, we're also enthusiastic looking at these results, but could you say a few words on the toxicity, not the financial, the physical toxicity?
Well, I think that you should never treat with immune therapy if you're not capable of doing a very strict follow-up on the patients and have a knowledge of how to manage the side effects. We have 2 patients with hepatic failures hospitalized in our ward after treatment with immune therapy. They're on one of the phase 1 studies, but regardless, we see everything. Heart failure, kidney failure, everything. And we are very, very strict, meticulous on the follow-up. The quality of life is so much better with the toxicity, but toxicity is not neglected. And you need to know what you're doing, because people, I think on the Checkmate 025, our first patient was randomized to nivolumab, and he died after 1 week. And it took me, I have to say, that this was a long time ago. This was, I don't remember, this was maybe 6 years ago, or 5 years ago. It took me 2 years to understand that he had myocarditis, that he was in the internal ward, and we didn't have time to understand, and he died. But eventually I figured out what happened. And today we are very quick with that. So we ask our cardiologists to look for autoimmune myocarditis. They can look it up at the echo test. There are signs. And we're looking at a lot of factors that we weren't aware of them before, and even kidney infections and a lot of routine endocrinological, and they come to our nurse twice a month. We don't want to miss out those patients. And certainly those are fatal cases. We see melanoma patients who died that you miss out that they had Crohn's disease before, and then it's like bursting and it's exploding. And also, I do want you to talk about something else. Gustave Roussy published the hyperprogression phenomenon with the immune therapy. And we saw it from day one. And you have to keep in mind that about 9 to 10% of the patients will have an opposite response to immune therapy. And the disease after the first or second treatment explodes. And there is very low chance that you get to treat them in another line of therapy, and they usually die very quickly within a month. And this is amazing. You have few lymph nodes, and after the first dose, there's disease everywhere, and the patient is gone. And you have to be aware of it. This is higher rate than the pseudoprogression. So you always have to look at the patient. You have to know to manage the side effects. You have to know that even headaches are related, can be related to immune therapy, hypophysitis, and other responses that cause even headache. And you have to be very, very on top of what you're doing, and not just look at the quality of life. It's easy, just IV every 2 weeks, just go home and come back. look at the data and look how the management, there are very good ESMO guidelines on how to manage toxicity of immune therapy. I strongly advise that all of you keep it on your laptop.
I think the lesson from what you just said is that these treatments that kind of, you have the feeling that everybody can give it, every urologist, pulmonologist, everybody can give it just so. I mean, it's correct perhaps for certain percent of patients, but it's dangerous, I think, for many patients. And these treatments should be given only in specialized centers that have routine protocols, how to follow and how to monitor the patients, and should not be done like everywhere. Also, the decision what and which drug should be given should be done only by specialized centers with oncologists that are dedicated to this issue.
I think
it's true for
else.
Israel. We have this discussion in Israel. I think it's going to be true, and it's true for the Ukraine and for the worldwide. I think so.
Yes, this in Israel, it's a hot topic because in Israel, the urologists want to start treating with immune therapy. And this is a huge dispute that we have with them. And just, we are horrified when we just yesterday, before I came, a patient walked into the ER 2 days before with jaundice. Liver enzymes were in the thousands. Bilirubin was about 9 or 13, I don't remember. He received in a different center in Haifa, EP-Nivo for melanoma, and after the 4th cycle, he didn't feel well. It was a holiday season, they were closed, he didn't go in, he was yellow, they called, they said, we closed, come after the holidays. After the holidays, yeah? So he walked in, they saw him in the ER, they didn't even call the oncologist. The internist said it's probably drug toxicity and sent him to the internal ward, and he didn't call the oncologist. Internal ward called the liver consult and the pharmacovigilance consult, and they all wrote that this is a drug-related, treated with steroids. No one called the oncologist, and the person late, he was 2 days in internal ward, didn't start steroids yet. So, even in the same hospital, awareness is very important. And it's very, 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 very tricky. So we give very good drugs, very new agents, but they come with a price. Imagine what's going to be the price of the EP-Nivo cabozantinib. It's crazy, but tomorrow someone said, let's give it. It's pills, and every 2-3 weeks, IV, that's it. So, like everything else, do the few things you do and do it best. Okay, thank you. So
Thank
we'll
you
talk
very
later.
much.